Hello everyone, welcome to Patho Excellence. In this pathology practical exam video series, today we are going to discuss gross specimens of general pathology, which is the syllabus of first internal examination. So in this video, we will discuss all the gross specimens related to general pathology only. In last video, we have discussed what is the standard format to speak in Viva for the gross description in detail. So, you include size, shape and color, external surface, cut surface, any special features like necrosis, hemorrhage, and conclude the diagnosis. So, in the last, you have to give the probable diagnosis according to the observed features. Now, before you learn gross description of particular organ, there are some organ specific terminology and you use these words while describing and concluding. So, for the heart, if we see, uh, for the specimen of heart, you have to use word like whether it is enlarged or normal in size, pale yellow area or whitish area, or infected area is present or not, whether the area is having hyperemic border, whether the ventricular wall is thickened or it is thinned out. So, according to this organ specific terminology, you have to describe first and the last line will be suggestive of myocardial infarction if these are the features. Now, in case of lung, you use word like consolidated, firm and heavy, whether cavitary lesions are present, caseous material for the granulomatous inflammation, gray or red hepatization for the pneumonia. So, organ specific words help you to remember the diagnosis. So, here if you have a hepatization red or gray, then it is lobar pneumonia. If it is having cavitary lesion or if you can see caseous material, then it is tuberculosis. Now, for the brain, use word like whether softened area or hemorrhagic area present, cavitary lesion, necrotic area, etc. So, here whenever you find cerebral infarction or intracerebral hemorrhage, you have to use words according to this diagnosis. Now, for the lymph node, whether it is enlarged, matted or having cheesy cut surface or firm in consistency. So, these are the words related to tuberculous lymphadenitis. Now, for the liver, whether it is enlarged, smooth surface, mottled or yellow greasy cut surface, nodular surface. So, these are the words for fatty liver or nutmeg or cirrhosis. Gallbladder, whether it is contracted, having thickened wall or fibrotic in appearance, presence of gallstone in lumen, flattened mucosa, these are all features related to chronic cholecystitis. And whenever mucosa, if you can see, you have to use velvety or roughened or eroded or ulcerated, fibrotic, etc. Gallstone, whether present or absent, if present, what are the numbers and size of the gallstone, and don't forget to say color of the gallstone, whether it is pigmented, green, black or yellow or mixed in color, right? Now, for the kidney, whether it is enlarged, golden yellow, areas of hemorrhage, necrosis, dilated pelvis. So, these are all words related to renal cell carcinoma. If it is dilated pelvis, hydronephrosis. For the stomach, ulcero-infiltrative lesion, thickened rigid wall, loss of rugal folds. These are all related to carcinoma, stomach. Intestine. So, whether you find growth, whether it is having annular constricting or napkin ring appearance, ulcerative growth or polypoidal lesion, multiple polyp is whether sessile, pedunculated. So, you have to use words when you describe either malignancy or any polyp. For the breast, whether the lesion is well circumscribed, whether it is hard irregular mass, gray-white cut surface is present, hemorrhage or necrosis present. So these are features related to fibroadenoma or CA breast. In case of uterus, whenever there is specimen of leiomyoma, use word like enlarged uterus, a firm mass, well circumscribed lesion, whorled cut surface, and ovary, whether it is cystic, solid, having smooth outer surface, containing hair, tuft or tooth or sebaceous material. These are the features of mature cystic teratoma. Soft tissue lesion, whether it is well circumscribed, capsulated, pseudocapsulated, soft, yellow greasy cut surface, lobulated. So these are all features related to lipoma. So remember all the words and terminology to describe particular specimen, and this will give you a great hint when you identify gross specimen. So let's see one by one different gross specimens and its description. So from the cell injury, if we see, first specimen commonly asked is fatty liver. So this is the specimen. We have to mention size in centimeter and in 3 dimensions. So this is the part of liver measuring external surface. If you can identify, or if you have a specimen, you rotate specimen from all side and see whether you find anything abnormality on outer surface or any particular area. Now cut surface, it is yellow, greasy, bulge out, and this is the diagnosis of fatty change. So yellow, greasy surface, enlarged liver related to fatty change, or it is called hepatic steatosis. And what are the commonest questions, like what are the causes for this fatty liver? So you should know some of the causes like alcohol, obesity, diabetes. It is a reversible type of cell injury, and there is intracellular lipid accumulation. Second specimen is, here the specimen is of heart already cut open. You can see brownish discoloration of the heart wall, and this specimen is having atrophy. So it is reduced in size and brown in discoloration. So it is called brown atrophy of heart. So this is a lipofuscin pigment deposition in the cell. So this is related to old age or cachexia, and lipofuscin pigment is having another name, wear and tear pigment, and this is shrunken heart with brown pigmentation, which is brown atrophy. Now this is a phenomenon of like autophagocytosis, because aging and cachexia will lead to this phenomenon, and there is wear and tear pigment deposition which ultimately lead to atrophied heart, and because of abundant lipofuscin pigment there is brown colored appearance. Now if we see necrosis, so there are different types of necrosis. So related to this, first commonest specimen you will see in exam is tuberculous lymph node. So how will you identify lymph node? So lymph node are generally multiple round matted soft tissue, and you have to describe as the standard protocol what is the size of this lymph node. Multiple lymph node having this by this size, largest one is this much in size, and it cut surface is showing whitish cheesy material, and this is the caseous necrosis. So most probably this caseous necrosis gives you hint that it is a tuberculous lymph node. Now this lymph node are matted and enlarged if this cheese like appearance is identified in any other organ. Suppose you are having specimen of lung and you find caseous necrosis. So then it is the tuberculous inflammation in lung, right? Now, coagulative necrosis. So it is the most commonest organ which is asked in a exam for this type of necrosis is heart. So myocardial infarction is for the coagulative necrosis. So this is the specimen of heart. Here there is a slice of heart already cut and you can identify this is the right ventricle, this is the left ventricle, and left ventricular wall as well as interventricular septum shows here well demarcated yellowish white area with hyperemic border. See, you can identify this reddish line surrounding this yellowish white area. So this is hyperemic border and this is infected area. So this is coagulative necrosis where in the microscopy you can identify architecture is preserved and it is caused by the ischemia. So because of loss of blood supply there is a coagulative necrosis. Here again the specimen of heart you can identify and most important feature you can identify is the whitish area and grey white homogeneous areas present all over the left ventricular wall even on the interventricular septum. So this is right ventricular cavity, left ventricular cavity, whitish area, and here the important another feature is this is the thickened wall or hypertrophied ventricular wall. Wall thickness is increased here and this is this is the diagnosis of myocardial infarction, but it is healing stage. So it is called healed MI specimen. Another type of necrosis is liquefactive necrosis. Most common organ involved by this necrosis is brain. So here this is the specimen brain slice. You can identify here the liquefied area and some of the area show hemorrhage. So this is the liquefied necrosis and specimen of brain abscess and this is due to enzymatic digestion. Now fat necrosis. Most common example of fat necrosis is acute pancreatitis. So this is here the specimen showing the pancreatic tissue as well as surrounding fat and here these are the white chalky deposits present in this foci of fat and this is called saponification and this is due to enzymatic necrosis of fat. So this is fat necrosis. If we see cellular adaptation, the most common example is cardiac hypertrophy. So here in this specimen already cut open uh, in the heart you can identify ventricular wall hypertrophy and there is dilated chamber also. So this is hypertrophied heart, enlarged heart, thickened ventricular wall. You can have to you have to describe what is the size of the heart and is there any on the external surface is there any area of hemorrhage or necrosis even on the cut surface as we have seen in myocardial infarction whether you find any yellow or hyperemic border or any fibrotic area or not, but here only the wall is thickened without any infected area. So this is the specimen of cardiac hypertrophy and it is due to pressure overload. Here hypertrophy means increase in cell size, not the number. So this is the classic example of hypertrophy. Now atrophy, here the testis is normal, testis is here and here this is the reduced testicular size and it cut surface show shrunken parenchyma. So this is a specimen of testicular atrophy. So atrophy is the where the size of the cell is reduced and it will give the appearance of atrophied specimen. Another example of atrophy is, already we have discussed, brown atrophy of heart. So same thing, atrophy related changes in the heart, here atrophy related changes in the testes. Now, what are the different pigments? So pigments related specimen most common are anthracotic lung. So anthracotic is black colored pigment. So whenever there is excessive deposition of black colored pigment in the lung parenchyma, it is called lung anthracosis. So here you can identify two specimen or both the lung specimen, and this outer surface is totally blackened and abundant black pigmentation on the pleural surface, and in the cut surface also the lung parenchyma is blackened and totally replaced normal parenchyma. So this is the anthracotic lung. Second pigment is brown induration of lung. As we have discussed, brown atrophy of heart, this is lipofuscin pigment, and lipofuscin pigment is also known as wear and tear pigment. This is a lung specimen showing brown induration, means brown colored appearance of lung, and this is due to chronic passive congestion. It is in the case of atherosclerotic heart disease. What happened exactly in the pathologically, if we see pathogenesis, there is chronic passive congestion in the heart, chronic passive congestion in the lung, because there is a left sided heart failure. What happens, according to the normal circulation, the lung parenchyma get blood from the right atrium and right ventricle, and after oxygenation this blood will go to left ventricle and left atrium and left ventricle. Whenever there is left ventricular failure or any heart related disease or mitral valve stenosis, lung will be the organ where the excessive congestion is there, and because of congestion the RBCs in the lung will be hemolyzed and there is separation of hemosiderin pigment, and this is called heart failure cells. And these macrophages are abundant in number in the lung parenchyma, and this is giving color to the lung like brown in color. So brown induration of lung, it is due to hemosiderin pigment, and brown atrophy of heart is due to lipofuscin pigment. So in both the organ the pigment deposition is different. So always remember, brown induration is due to hemosiderin pigment and brown atrophy of heart it is due to lipofuscin pigment. So here pathology, if we see congestion, there is edema and leakage, then capillary rupture, RBC breakdown, macrophage will take excessive hemosiderin, then become heart failure cells, and in chronic phase it will lead to fibrosis. So lung will be becoming hardening and it will give a heavy firm brownish color, and microscopically you will find CVC lung changes and hemosiderin laden macrophages. Then another example of hemosiderin pigment is hemosiderosis liver. This is the slice of liver specimen where you can see the excessive brown pigmentation on the surface. So it is hemosiderosis, and it is due to excessive amount of iron and ferritin that form hemosiderin granules, and this is the hemochromatosis. Now if we see the organs from inflammation, so one is acute appendicitis. So Always see this is the tube like structure, elongated. Here you can identify already cut open, and you can see appendix in two pieces already cut open in from the center. So outer surface, whether it is enlarged or congested or not, serosal surface, which is outer surface, and it is dull. If you find any pus or purulent material here, then describe, otherwise always skip this and tell whether it is enlarged or not. And most common, it is a patient present with the surgical emergency and perforation. So this is the specimen of acute appendicitis. Now another acute inflammation specific organ is lobar pneumonia. So this is the specimen of lung. Here, if you describe this specimen, you can see this is the already cut open lung specimen, where the cut surface show upper part of the lung showing blackening anthracotic pigment deposition, and lower part show one lobular consolidation showing grey white in appearance, and this is due to grey hepatization of uh, phase of pneumonia. So there are four phases of pneumonia. First phase is congestion, second is red hepatization, where there is excessive amount of RBCs in microscopy you can identify. Third stage is grey hepatization, where there is consolidation, means thickening. Lung is generally spongy organ, but whenever there is pneumonia, this type of hepatization, why it is called hepatization? Because it is having consistency like liver. So it will become firm in nature and it will having a liver like consistency. So this is called hepatization. Why it is grey? Because it is having a grey brown appearance. So it is grey hepatization, and this is the third stage of pneumonia. So first is congestion, second red hepatization, third is grey hepatization, and last one is resolution. So here this is the specimen of lobar pneumonia, but you have to identify this is the area which is actually a consolidation area, right? So describe that the lower part of this lung specimen shows a consolidated area, and try to describe the area in size. First you have to give lung size, second any lesion like here consolidated area is measuring this by this centimeter. So this is a grey hepatization stage of lobar pneumonia. Now cholecystitis, this is a chronic inflammation. So here the gallbladder wall is thickened, the normal rugosity or mucosa is replaced by this fibrous wall, and you can identify these multifaceted stones. So this is called specimen of chronic cholecystitis. And now let's see infarction. So this is in the hemodynamic disorders. So there are two types of infarct. One is white infarct, second is red infarct. So here you can see this is the specimen of kidney or the slice of a kidney specimen. Here the cut surface shows a wedge-shaped pale yellow-white area, where the base is at the toward the capsule, and it is sharply demarcated area, and this kidney is showing congestion. You can appreciate here red lining. So this is a congested, but here there is infarction. So there is a loss of blood supply, and this is called white infarct or anemic area of kidney, and this white infarct usually occur in solid organ where there is end artery supply, and this is the example of coagulative necrosis. Now red infarct. So red, as the name suggests, it is red in color. So here this is the part of lung, and these are the wedge-shaped dark red color area present in the lung parenchyma, and most common example of red infarct is in lung and intestine where there is dual blood supply. Another example of red infarct, here you can see this is the hemorrhagic infarct in brain. So this is a slice of brain where red infarction area present in this area measuring this by this, and this is here the cause of this hemorrhagic infarct, it is due to reperfusion injury. Whenever patient present with any emboli or thrombosis and patient is given treatment for the reperfusion, then there are chances of red colored infarct in this particular area. So here with the venous occlusion, red infarct it will be seen in testicular and ovarian torsion. It is also seen in loose spongy tissue like lung where there is infected area you can identify. Tissue with dual circulation like lung and small intestine, and here because of reperfusion of infected area we can find this type of hemorrhagic infarct. Now this is important Viva question, how will you differentiate and what are the differentiating features in white or pale infarct or red and hemorrhagic infarct. So arterial supply, wherever there is single end arterial supplies, it is white infarct. It is due to arterial occlusion. Solid organs are affected like heart, kidney, spleen. Morphologically, it is pale and well defined area. Size, usually small in size. Wedge shaped where base is towards surface. Edema is minimal. Type of necrosis is mostly coagulative, but in brain it is liquefactive, and hemorrhage is absent. As the name suggests, red hemorrhagic infarct, it is red in color. It is the commonest in where the dual blood supply is there. And so these are the organ like lung, intestine, testes. Arterial or venous occlusion is there. Then loose and spongy organs are mostly affected. It is generally poorly defined as compared to this pale infarct, and it is again a type of coagulative necrosis. Now thrombus. So here these are the two specimens showing a vessel having thrombus in the lumen. So this is a pelvic vessel where you can find this presence of thrombus red in color, and here this is the part of lung, and this great vessel shows pulmonary thromboembolism. So gross description, it is firm mass attached to vessel wall. You can find line of Zan on the cut surface, and this is the thrombus. So what are the Viva question? What is thrombus? It is formed in the living circulation, and line of Zan means there are alternative dark and light lining in the thrombus, which is due to presence of RBC and fibrinous material where it give red as well as white in color appearance. So commonest question, difference between antemortem clot and postmortem clot. So antemortem it is thrombus, postmortem it is clot. Antemortem before death, it is true thrombus firmly attached to vessel wall, cut surface is dry, dull and rough and friable and firm. Color, it is gray and white and red alternative lining because of fibrinous and platelet and RBCs presence. Line of Zen presentation is laminated appearance. Shape is molded to vessel lumen. It is due to underlying endothelial injury and inflammation, and it causes ischemia, infarction, embolism, and most common is coronary artery thrombus. Postmortem, it is after death because of blood coagulum. It is not attached and easily removable. Shiny and gelatinous in appearance, it rubbery in consistency. It is having dark red lower part and yellow upper part, and no line of Zen is present. It is having normal vessel wall and no clinical significance. But whenever we do grossing, we have to see for whether it is antemortem or postmortem. So these are alternative line you can appreciate: white line, then red, then white. So these are the line of Zen. This is the gross appearance. This is the microscopy appearance where alternative light pink and red line are there. So this is the antemortem thrombi, and this is the gelatinous homogeneous material. This is postmortem clot, and this is due to stagnant blood in the vessel wall. So this is not having line of Zen in this postmortem clot. Another specimen is now example of chronic passive congestion is nutmeg liver. So here you can see as the standard approach that this is a part of liver, piece of liver, where it is measuring this by this centimeter, external surface smooth, cut surface mottled, having a characteristic mottled. So here you can alternatively you can find brown and light area. So dark reddish brown, it is congested area, and nearer to this yellow pale area, it is resembling the nutmeg cut surface. So it is called nutmeg liver. Why it is looking like this? Because congested in the microscopy, if you see the congested central vein and the surrounding hepatocytes are having fatty change. So these are the giving yellow appearance, and this is the red color appearance. So this is red and yellow alternative area. So this is chronic passive congestion of liver, and the cause is here right sided heart failure. In case of CVC lung, it is due to left sided heart failure. So here mottled appearance. So this is a nutmeg, and you can compare this cut surface with this appearance of nutmeg, appearance of liver. So this is the our specimen of nutmeg liver. Here you can identify the outer surface is mottled, having alternative dark and light area. This is again another surface of this nutmeg liver specimen. So how will you differentiate nutmeg liver and fatty liver? According to the its appearance and color, it is mottled. Here it is uniform, yellow in color, congestion present, and zone affected is zone 3 in microscopy, and all zones are affected. And here right heart failure, here it is alcohol, obesity, diabetes, etc. Now granulomatous inflammation. So already we have discussed tuberculous lymphadenitis. This is the example of granulomatous inflammation, example of caseous necrosis. Here these are the specimens where you can compare two specimens. One is having this tiny millet shaped caseating nodules, right? So millet means small tiny typically grains having whitish caseating material. This second specimen, you can see these are the whitish solid area varying size in shape but large in size compared to this caseous nodule. So this is, both the specimen are of lung. Here it is a specimen of miliary TB. Here the specimen where the lung having metastasis. So what is metastasis? In your neoplasia chapter, malignant tumors are spreading to another site where it gives here metastatic nodule in the lung. So this is the example of granulomatous inflammation where the specimen of lung, here this pleural surface you can identify black in color, but some tiny millet shaped caseating nodules are present. This is the cut surface where the whole cut surface is involved by this caseating tiny millet shaped nodules. So this is a specimen of miliary TB, and here this is the metastasis in lung. Now, what is miliary tuberculosis? It is due to hematogenous spread of tuberculosis. It is millet seed appearance, and because it is having 1 to 2 millimeter in size tubercle, so caseating or miliary tubercle. An example of caseous necrosis, most common are liver, spleen, bone marrow, kidney, meninges, and microscopically what you find is granulomatous inflammation, so epithelioid cell granulomas with Langhans type of giant cells and central caseation. How will you differentiate miliary TB and anthracosis? Miliary TB already we have seen, it is having tiny tubercle 1 to 2 mm but grey white. These are the black pigmentation present in the anthracosis, and this is due to carbon particle or coal material. So this is due to inhalational, this is hematogenous, and this anthracotic or anthracosis is common in coal miner patients. Now, what is the difference between miliary and metastatic deposit? Already we have discussed, having size difference, here 1 to 2 mm, here it is variable size, and this is cannonball appearance resemblance, here it is millet seed, and this is metastatic spread and metastatic lymph node, here associated caseating lymphadenitis is there. Amyloidosis. So amyloidosis is here in this specimen of kidney. You can see cut surface of kidney showing um, pale appearance, smooth and waxy appearance. Kidney is enlarged, and this is the renal amyloidosis. How will you confirm? Microscopically with the help of spatial stain. So what is the spatial stain? Congo red, and it is apple green refrigerance when we use polarized microscope. Now another example of amyloid is spleen whenever is involved. It is called sago spleen or nodular amyloid deposition. So here this is a specimen cut surface of spleen showing sago. These are the sago. So sago grains resembling appearance of this nodular, whitish nodular appearance in the spleen. It is enlargement of the specimen, and it is due to periarterial lymphoid sheath where white pulp is involved by this amyloid deposition, and here this is lardaceous spleen. So here diffuse deposition of amyloid pigment and resembling lard, it's showing map like areas resembling lard. So microscopically if we see amyloid deposition, it starts in the walls of the sphenic sinuses and progresses till they form large diffuse mass. So sago spleen and Lardaceous spleen both are example of amyloidosis of spleen, and these are the two patterns of appearance. Now neoplasia. Here you can see this is a cut surface of uterus, and this is the outer surface of uterus. So uterus, cervix, but you can appreciate multiple whitish well circumscribed nodules in the myometrial wall. So this is the specimen of fibroid uterus. Now what is fibroid? So it is the smooth muscle tumor which is benign in nature, which is called leiomyoma. So myoma, oma suffix is always for the benign tumor. Here some exceptions are there, but here it is a smooth muscle tumor of uterine smooth muscle, and these are the leiomyoma or fibroid of uterus. Here this is the cut surface or bisected uterus with cervix, shows multiple nodules in the whole myometrial wall of whole uterus, measuring largest measuring this by this, or you can say whether it is 2 by 2 or 3 by 3 or 4 centimeter in diameter. Smallest measuring, here you can see it is either 0.5 or 1 centimeter in diameter. Cut surface show whorled appearance. So here you can appreciate these are the different types of leiomyoma. So whether it is when you learn in systemic pathology, female genital tract, you will learn what are the different uh, types of leiomyoma according to, or what are the different names of leiomyoma according to the location, whether it is uh, intramural or subserosal or endometrial, right? So this is specimen of leiomyoma uterus, which is benign tumor. This is specimen of fibroadenoma of breast. So by fibroadenoma, by definition, it is benign tumor of breast parenchyma where there is fibro means stromal component as well as glandular component. So there is expansion of uh, or overgrowth of stromal as well as glandular component. So it is named as fibroadenoma. So here the gross description, it is bisected, lobulated mass, well circumscribed, round to ovoid mass measuring this by this, and smooth encapsulated, having some slit like spaces. Here you can identify no areas of hemorrhage and necrosis. So this probable diagnosis is fibroadenoma of breast, which is benign breast tumor. Another specimen showing similar feature, this is a fibroadenoma of breast where you can find some slit like spaces and homogeneous cut surface. This is also a specimen of fibroadenoma breast, and some slit like spaces are present. It is due to uh, intracanaliculaar pattern of the growth, which you will learn in your systemic pathology, and we will describe in detail when we learn systemic pathology in detail. This is gastrointestinal polyp. So here in this specimen, how will you describe? So this is a specimen consists of segment of gastrointestinal tract, where multiple polypoidal uh, lesions are seen, which is projecting into the lumen. This polyp is pedunculated. Whether it is sessile or pedunculated, you have to describe, and whether it is lobulated or smooth in or in appearance, and whether areas of hemorrhage, ulceration or necrosis present or absent. We have to mention here. You can identify hemorrhage. In this specimen, you cannot identify any hemorrhagic or necrotic area, but some polypoidal growth is there. So this is a specimen of GI tract, and this is a colon specimen. How will you identify? With the help of its outer surface, and this is a benign tumor of gastrointestinal tract. So in exam, you have to identify whether it is small intestine or large intestine. So for that, there are some differentiating point where you can judge. So in this specimen, uh, this is the large intestine specimen, right? Because there is presence of this fat lobule. So what is the name? It is appendices epiploicy, and the differentiating points are small intestine and large intestine. They are, if we see length, it is long, here it is short, but we in exam we are getting only the piece of intestine. Diameter, yes, important. Narrow lumen, it is wider lumen. External surface, it is smooth. Here it is sacculated. Tinea coli, which is band-like structure, you can identify in the intestine. So it is present in large intestine. Appendices epiploicy, these are the fat lobules present on the surface. So this is in this specimen, this is the appendices. So you can identify this is the intestinal or large intestine or colon specimen. Now mucosal fold, plicae circular is present, here it is absent. Internal appearance, circular fold are there, here irregular, smooth fold. Wall thickness, thicker wall in the large intestine, thinner wall in the smooth intestine. Lymphoid tissue, pairs patches in ileum and duodenum, jejunum and ileum having a different microscopic morphology that we will learn in detail in systemic videos. Mesentery present in small and large intestine, but in large intestine present only in the transverse and sigmoid colon. So this is a specimen you can identify. Here you can see these are the two pedunculated polyps. So this is peduncle, where it is polyp is with the help of this peduncle, polyp is attached to the mucosal surface of intestine. This is sessile polyp. Here also these are all sessile polyp which are present in the intestinal wall. So this is basically for your first term exam, a benign neoplasm of intestine. So these are the example of this benign neoplasm of GI tract. Now lipoma. So this is benign tumor of fat tissue. Here this is the specimen, well circumscribed, encapsulated soft tissue mass, yellow in color, homogeneous in appearance, no hemorrhage, no cystic area, no necrosis, and because of its yellow appearance and well circumscribed nodule, it is lipoma. and it is greasy in cut surface. So this is a benign tumor of fat. Now, mature cystic teratoma or dermoid cyst of ovary. So here, this is the already cut open cystic area where you find hair tuft. So very easy specimen to identify for your exam is this, because only hair tuft will indicate this is the mature cystic teratoma. Here again, this is already cut open cystic ovarian mass, where in the lower part of this cyst you can identify some hair tuft and some sebaceous material. This is the cut surface, this is outer surface, so this is mature cystic teratoma or dermoid cyst of ovary. Carcinoma of breast, it is a malignant tumor of breast. So for the neoplasia, you have learned benign tumors in the form of lipoma, fibroadenoma, leiomyoma, and polyp intestine, and last one is lipoma. So here it is now tumors of breast which is malignant in nature. So here this is the gross specimen. Outer surface is identified by thick skin and nipple areola unit. You have to measure this by this size of this specimen. Cut surface show homogeneous, hard and white mass which is infiltrating into surrounding fat tissue. This is grey white appearance, stellate shape, and this pink color is due to inking of the surface. Whenever we receive specimen for the tumor, we generally ink the specimen. So this is the inking color or ink which is used to uh, see the base of the surface this specimen, so that in the microscopy we can identify whether base is involved by tumor or not. So this is a specimen of infiltrating duct carcinoma which is malignant tumor of breast. So for this you can have questions about what is the difference between benign and malignant tumor. So here you have to learn definition of neoplasia, difference between benign and malignant tumors, what are the examples of benign tumors, what are the examples of malignant tumors, like this. So you have to read theory accordingly. So this is again the specimen of breast tumor or infiltrating carcinoma of breast. This outer surface is identified by the nipple areola and skin and surrounding fat. This cut surface shows this gray white solid mass in the fat of the breast tissue. So this is a breast carcinoma. This is the example of malignant tumor of colon. This is called CA colon or carcinoma colon. Here you can describe this specimen like this is a segment of intestine where measuring this by this centimeter. Here the upper part of the specimen look normal, but the lower part is showing a growth which is ulcerated in nature. The uh, wall of the colon is thickened, irregular in shape. The ulcer base is having necrotic material, and you can also describe this lesion in the centimeter, means this by this in centimeter, and this is the adenocarcinoma. Probable it is adenocarcinoma of colon, or it is called annular constricting ulceroproliferative growth causing luminal narrowing. So this is normal component, this is luminal narrowing, ulcerated, and this is a proliferative growth. and you can appreciate this is napkin ring appearance. So it is here you can appreciate it is constricted area. So constriction is there and this is called napkin ring appearance. This is again a tumor, malignant tumor of kidney. So first of all you have to identify which organ is this. So with the help of this appearance of lower pole you can identify with the help of pyramidal and cortex area. This is normal part of kidney. So this is normal part of kidney. Here the upper part is abnormal. You can appreciate. So this is the already cut open or bisected kidney where the upper pole shows this type of yellowish golden colored growth. Right. So these are the malignant tumor in the kidney. Here you can say this is a specimen of kidney, already or partially bisected kidney with large intrarenal mass which is having variegated appearance and the lower pole is uh, spared and upper pole is involved by this malignant tumor. It is having appearance of grey white to yellow and this is a specimen of renal cell carcinoma. This is again a specimen of stomach where already cut open stomach is there. So here first of all you have to measure the size of the specimen, but you cannot find, if you don't find any growth you have to describe that this is a cut open stomach having thickened wall, loss of rugosity and appearance is like leather bottle. So this is called leather bottle appearance of stomach or linitus plastica type carcinoma stomach. This all you will learn in your systemic pathology when you learn GI tract. Here you have to just remember this is the specimen of malignant lesion of stomach. So here it is related to your neoplasia chapter. So this is the carcinoma stomach, diffuse type, linitus plastica, and this is called leather bottle appearance. Here how you how you describe the specimen in gross viva that is covered for general pathology, and these are the some commonest specimen which can be asked in your exam in first internal. This is the list. So I hope now you will use this standard format and you will uh, do this you will use this approach for the describing specimen in particular order, and if you find any difficulty whenever you see the gross specimen, you just describe the specimen, what it is, try to identify which organ is this and which type of lesion or any abnormal area you can identify and try to describe it. Even if you try to describe this much, examiner will know that you know which organ is there and how to you know how to describe the specimen in correct order. So this will also give a good impression and examiner will also guide you to reach the diagnosis, right? So I hope now you will be very happy to uh, see and identify gross specimen when you go to practical exam, And if you found this video useful, like and share with your batchmates. And thank you for watching. Happy studying and all the best for your exam. And in next topic, we will do some uh, practical revision for microscopy as well as some table vivas. So thank you.